like a work thing, but I can be
Morning.
Good morning, Anna.
Hey, Jeff. How are you?
Real good. And you?
Very well. Very, very well. Got
So
bronze.
there's
Hi,
only
bronze.
3 of us.
Yes, yeah. So far, there's always some stragglers. Jeff, are you still involved in the Lions Club?
Yeah, oh yes,
Are you? Yeah.
heavily. Yeah.
Yeah. And what are their sort of activities at the moment? Is there anything in particular they're working on or?
Well, our own club. We just tend to distribute money as it's needed, but in the broader scheme of things, we've got a number of foundations, like the Children's Mobility one, for instance, where most clubs contribute to it, and they provide walkers for kids that are handicapped so that they can become mobile. That's one example of many
Sort of
of them.
activities. Yeah.
Yeah.
I'd be interested if we can, probably this is the wrong forum to discuss this, but I'd be really interested to talk to you about Lions Club activities and just have a chat offline, if that's all right.
Sure.
Can I hit you up?
Yeah,
Okay.
good idea. Yep.
And Julian, hi. I've actually been meaning to reach out to you as well.
Hello.
I want to talk to you about how you went from like small animal or clinical practice into your wildlife work and just like how that pathway went. But this is not the forum. And hi, nice to see you.
We can catch up outside of this.
Yeah, sounds good. Awesome. Good morning, everybody.
good morning.
We'll stop socializing and start learning. Ready? So today's topic is CPR. And realistically, I think CPR needs to be taught practically, like with dummies and things like that. But I did dedicate the whole session to just the one chapter because I think it's something that it's really nice to know it and feel fresh on it, because when it happens, it's just a nice revision, right? To go through it. And then the other thing that's happened that warrants like a little bit more time for discussion is that the Recover Initiative. Has everybody heard of the Recover Initiative? Yes, great. So it's this group that are kind of standardizing guidelines around CPR in animals, which is absolutely fantastic, because everything that we've done up to the point where this group got together and started coming up with consensus has been extrapolated from humans. We don't have a lot of outcome data from dogs, and they've just been collecting so much information, talking to people that do CPR all the time and what the sort of things that predict outcomes are. So they've come up with updated guidelines as of 2024. So brand new guidelines, which mean that we can draw on the evidence that they've gathered over their first guidelines, which came out a long time ago, and update the way that we're doing CPR. So rather than go through like CPR in detail, I want to go through what the updates are and why, if that's all right with everybody. Cool. So first things first, does everybody know kind of definitions? Like what is basic life support?
It's compressions and definitely compressions and plus or minus
ventilation,
respiration. Yeah, breathing.
Great, excellent. And what about advanced life support? What does that encompass?
That would include, I would say, a defibrillator if required. I don't know in animals.
Well, it's actually mostly kind of monitoring stuff.
Right. And
to
any
sort of think that way.
like in hospital versus out.
Yes, exactly. Yeah, exactly. So basic life support is what you can do in community. Advanced life support is when you start to get a little bit more advanced about what we're monitoring and what our I guess how successful a delivery of basic life support is. So that encompasses monitoring equipment, what monitoring equipment might we use in CPR in a hospital setting?
ETCO2, the most important.
So, Pooja, you go.
Capnography, like you have to have a capnograph to see the ROSC. So
Excellent. Okay. And somebody said something else. Helen, I think.
An ECG.
ECG. They're the two. Yeah, exactly right. So why are we looking at ETCO2?
it's a guide of ventilation, oxygenation, and also metabolism, like the carbon dioxide circulation. That tells you all three parameters.
Yes. So what happens to the ETCO2 in a dead patient?
Presumably it'll be zero.
Exactly right. So what is happening at a cellular level? Are all the cells dead and not producing any ETCO2? Is that why we don't have a reading on ETCO2?
I think there's no circulation. So then you can't, like, I think that's the thing. There's no
Right.
circulation.
So at a cellular level, are those cells still producing CO2?
Initially, I would think yes.
Yeah, for sure. It takes a long time for the cells to actually die. So we get a lot of ETCO2 accumulating as a result of cellular respiration, which is ongoing, and energy consumption. And all of that is sitting in the tissues peripherally with no flow to bring it back to the lungs to be breathed off. Sorry, go visit us. Hey, here you are. Where's Vicky? Good morning. They'll be fine. They're fine. They look great. Bye. Bye. This afternoon. Bye. Bye. This afternoon. Bye.
Yeah.
Do the background. Bye. Yeah. Sorry. Sorry. We definitely said goodbye before I came upstairs, but apparently we needed another one. So the ETCO2, when we've got no circulation, is going to be really low, right? We've got no air being breathed out. Even if the CO2 is being accumulating in the lower lungs, it's not going to be breathed out without ventilation. So what are we looking for? Sort of two things that we're looking for when we're monitoring our CO2 when we're doing resuscitation. What do we want to see?
So the number,
Mhm.
like what it is, I think
Like
with the
it
new
really is.
guidelines, it's 18, greater than 18 for ROSC. And then also your the depth of your compressions, like how effective your compressions are. Because if they're not effective enough, you don't get that.
Air movement. Yeah.
Yeah.
Good. So is it greater than 18 for
Yeah.
return of
I think the new
spontaneous?
guidelines say greater than 18. I
Yeah,
had 15
okay,
in my
right.
mind earlier, but I think the new guidelines say 18.
Yeah. So in my experience, and I might be wrong, and I have to say this isn't my field. It's very interesting, but it's not my field at all. I haven't done CPR for like 10 years.
Yeah, I was very surprised to have this over here. I was like, oh, Anna's going to talk about this. Great.
Well, that's
It's not
what
really a medicine thing. You push this off to critical care.
yeah, I know. And it's not such a luxury to work in a clinic where there's a criticalist where you can say, excuse me, you do this.
But I think it's important for everybody to know.
Actually, yeah, exactly. And realistically, like we're doing ultrasounds and echoes sometimes in critical patients who haven't been able to pursue referral for whatever reason. And we're sedating them. So we are kind of triggering sometimes decompensation. So I should revise it. This is something that I want to feel more comfortable doing. So 18 seems low for me for return of spontaneous circulation because
I think it's 18 just to maintain your CPR, but then
that's what you're
return.
aiming for during CPR,
Yeah.
not
Yeah.
to treat, not as so ROSC that you said before stands for return of spontaneous circulation.
Yeah.
So typically when we get that, we get this huge spike in ETCO2, right? Because all of that CO2 that's accumulated peripherally is now flowing back to the lungs and it's got to be breathed off. So the ETCO2 should be very high. And that's one of the markers of ROSC. I'll say ROSC from now on instead of return of spontaneous circulation. but that's what I mean when I say that. So yeah, it shoots up really high. So that's one of the markers that without stopping doing compressions and compromising the patient's well-being, you can actually see that the heart started beating again. Good. So ETCO2. And what about ECG? What are we looking for on our ECG?
Whether there's like pulse, there's activity versus not, because then it differs what you're going to do next.
Yeah, excellent. And we'll get to kind of what we do with different ECG abnormalities down a little bit further. But what are the two kind of rhythms that are significant for CPR? PEA you mentioned, pulseless electrical activity, or asystole, basically. And what's the other one that we sometimes see that you might want to know about early in CPR?
VTAC.
VTAC, yeah, good.
Because then you might be able to
Fibrillation, ventricular fibrillation.
Exactly, yeah. So the reason for that, for sort of differentiating them, is it differentiates a shockable rhythm. So if you're in a setting where there's a defibrillator versus a non-shockable rhythm, essentially, if you've got any, like you don't need to like know ECG back to front, but if you've got any repetitive complexes with a rate of greater than 200, it's a shockable rhythm. If the rate's under 200, whatever the complexes look like, it's not shockable. So it's just a nice kind of like, there's the line. I haven't been in a place with a defibrillator handy for a very long time, so hopefully everybody else has got access to them. But I have to say shockable rhythms are rare in dogs. It's really only the like DCM or like Dobermans and stuff like that that develop VTAC.
What was the other one? DCM and what, Ellie?
I said Dobermans because they get VTAC.
Oh, right. Oh, so
yeah, and I should say boxers as well because they get ventricular tachycardia. Yeah.
But just DCM and dogs that experience ventricular tachycardia normally.
Exactly.
Right.
Yeah. Yeah, I don't know why. I've had a Doberman drop dead, so I've got that in my head. Other than that, it's like the only one that I've been like, yes, I can defibrillate it.
Because it's an issue of a cardiomyopathy, right? Primarily, like, is that why humans get VTAC? I mean, ventricular fibrillation.
So what causes it is damage to the myocardium, which disrupts the electrical circuits within the ventricle. So there's a few things that can cause that. So in humans, the reason it's why it's so much more common in humans is because they have myocardial infarction and then they have fibrosis following myocardial infarction. So there's like two potential causes of disruption of that electrical circuit. We don't really get that in dogs and cats. I think cats probably get it much more commonly than we detect because they get similar like myocarditis and stuff like that, where they have little focuses of fibrosis in their myocardium. But I don't think we see shockable rhythms very often because we just don't see those myocardial diseases. We see valvular diseases, which result in volume overload and atrial arrhythmias rather than ventricular arrhythmias. And they don't usually die from atrial arrhythmias. They die from congestive failure. Okay, good. So that's part of advanced life support. What about like other things that you might do in hospital in a patient that's presented in cardiopulmonary arrest?
You can give them oxygen via a ET tube and intermittent positive pressure ventilation.
Yeah.
And you can give them drugs according to the ECG.
Yeah. Lovely. So I like the drugs. What sort of drugs would you be thinking about using in patient with death? Sorry. I lost my words for a minute.
I can't remember the chart. I think you can use adrenaline in everything, but atropine only in some of them. I think is beneficial, but I can't remember when. I think I don't think atropine's useful if there's pulseless electrical activity.
Yeah.
But it probably doesn't. I don't know if atropine's ever contraindicated.
we will go into that in a little bit more detail because they have made more specific guidelines on atropine use, which is nice. What about if the cause of the death was in hospital?
And anesthetic reversal.
Yes, great. Yeah, anesthetic or opioid reversal.
Yeah.
Okay, good. And I have to say, so in human hospitals, 1 in 10 medications administered is incorrect. We must overdose or underdose patients all the time, and I don't think we've got the systems in place consistently in the veterinary world to know that we've done that. So even if everybody says, oh no, there's no overdose, or like, no, I just gave it a routine dose, I will probably just reverse by routine, like
Right.
agents that have been given.
Yeah.
Because they don't need them if it's dead. You can just reverse. Yeah. So I would assume that there's been an overdose even if there was no signs of that.
But I would think it's not just because if you're talking specific anesthetic, like opioids, that's what we're reversing, right? So it doesn't have to be an overdose. It can also be, can't it be an idiosyncratic reaction or like a drug reaction that this, like the sensitivity at this point is just like, ooh, and the animal's dead.
Good point. Yeah. Yeah. So I would reverse opioids, but also alpha to
whatever can be reversed. Like if there's medetomidine, then you'd give the
exactly.
atipamezole. Yeah.
Yeah. And how are you going to administer the atipamezole in this situation?
IV.
IV, yeah, exactly. Yeah, not going to get far if it goes into the muscle. So atipamezole is labelled for IM only, not labelled for IV. We use IV all the time in an emergency setting. And they wait, like, I mean, the settings that I use it in most commonly is that they're like too bradycardic and we're worried about the depth. And you give it IV and they go, they wake up like they've been naloxoned or junkie on TV that's been naloxoned. But yeah, it's definitely a comfort when they wake up like that. And the other things, you can reverse with benzodiazepines. Yeah, with
flumazenil, yeah. Not every place stocks it though, but it's a good thing to have. It's expensive. It's really expensive.
Is it? Okay.
Yeah.
Interesting. I have to say there's not many practices that I go into that would stock that. But also we don't use benzos that much apart from in status epilepticus. Okay, excellent. So advanced life support is monitoring, reversing the agents that we can reverse, and getting into access. Yes. Yeah. So fluid if indicated, depending on the cause of death, but
however, I think now this thing is you would only fluid resuscitate like aggressively if there is hypovolemia. So if the cause, like if the animal is not really hypovolemic, then you don't, because you will actually cause overload.
So even if they're like whole body hypovolemia, not just intravascular, like what about anaphylaxis? They're not hypovolemic. They've got all their fluid. They haven't lost it.
But aren't they pooling? Like most times, if they're going into like systemic anaphylaxis, they're pooling somewhere most times. That's why they get hypotensive. Like that's the very definition. I would think.
But but they're technically not hypovolemic.
Distributive shock.
Yeah. Anyway, I just like it might be a terminology thing, and maybe I've got the definition wrong of hypovolemia. But my understanding is that there's been volume loss or inadequate intake to keep up with losses, kind of thing. And that, yeah, when it's still in the system somewhere, like I get you don't want to overload them, but there might be situations where we might make an exemption to that. Okay, excellent. So that's kind of basic CPR. Is we're going to be doing chest compressions and ventilation, and then that's going to be our first priority, right? So what I thought we'd do is essentially just talk through the different kind of categories, like when do we start basic life support and the recommendations around that, and then like how do we actually position them and things like that, and what recommendations have changed there. So when do we start life support? How do we know that they need it?
I think you just start when you're not sure.
Yeah.
The patient is not obviously breathing and you're still trying to work out if they've got a heartbeat. Probably
Yeah.
start then.
That's exactly right. Yeah. So start earlier than you think, basically. So if they're not breathing, it doesn't really matter what their heart's doing, start compressions. Because at a minimum, your compressions are going to move air in and out, small volumes of air in and out of the lungs. If you're on your own, what are you going to prioritize? No, I don't want to move on to that yet. Sorry. So if they're not breathing, so this is the guidelines say if they're not breathing, start CPR before looking for a femoral pulse. If you're on your own, like you don't want to be delaying doing compressions because you're hunting for a pulse. Realistically, I think it takes longer to determine that they're not breathing than it does to feel a femoral pulse, and you can do that while you're looking to see if they're breathing, kind of thing. But if you're, for example, monitoring anesthetic that a patient dies under, you know then they've stopped breathing and you know you need to start compressions, and presumably you've got some more monitoring equipment on as well. So it depends on the setting, but always prioritize doing the compressions. Worst case scenario, you give them a bruised chest, but you got circulation going as quickly as possible. What about if you've got a patient that's just owners have rushed it in and they've said it's just been hit by a car and you determine that it's not breathing and there's a lot of you around, are you going to put a tube in before you start compressions, or are you going to start compressions?
If you have multiple people around, you start compressions, second person's putting the tube in. Like that's the whole team thing.
Yes. And what about if you're on your own? Everybody else is with the other CPR that came in 5 minutes ago.
Still start compressions.
Compressions. Don't worry about the airway. They do actually say, sorry, I should say that. They do say if you're on your own, an airway evaluation should be performed during initial patient assessment. So literally like hand down the back of the throat and just make sure there's nothing blocking the airway. Because if you're doing compressions and that's obstructed, you're going to cause pulmonary edema and more problems, obviously, and you're not going to be moving any air in and out. But you don't need to get a tube in, obviously, on your own. That's going to be tricky.
And I had the experience once of doing mouth to mouth on a human, who I subsequently discovered was already dead. But I got it'd gone blue in the peripheries, and I got I got the blue out of a lot of the peripheral things just with mouth to mouth. And I was only young at the time. I just finished school.
And he was dead.
Pardon?
And he was already dead. There was no circulation.
Well, apparently that's what the ambulance man said when he arrived.
Wow. He must have circulation if you resolved the cyanosis.
Yeah, I think what happened probably was the expansion of the lungs moved some blood around.
It caused some like cardiac compression by changing the pressure.
Yeah, and also just increasing intrathoracic pressure probably.
Yeah. So where that's a good point. So if we do IPPV, so intermittent positive pressure ventilation, we're going to alter the intrathoracic pressure and it will alter the heart. But if we have to choose, if we're one person, we're not going to affect the heart enough by ventilating, as opposed to like the way that we affect the respiration by compressing. You know, does that make sense? So if you have to choose between them, you always want to prioritize doing the compressions because you will get some air movement as a result of that. And there's more benefit to that than there is the heart movement that you get from IPPV. Okay. So if you've got 2 people, chuck a tube in while compressions are going on, but don't stop compressions to facilitate that, is the new guidelines. Next section is position of where we do our compressions. And this is the section where in the previous guidelines, there wasn't very good data on like dogs are such different shapes, right? Like how are we going to effectively compress these dogs and what outcomes are we likely to get with different shaped dogs. So where are you going to do your compressions on a French bulldog? How are you going to position the patient?
I think
Yeah.
dorsal and then do 1/4 of the thoracic depth for a Frenchie.
1/4, did you say? And what about position?
Dorsal recumbency.
Yeah. So essentially, if a dog lies on its back, like if it's positioned stably on its back, that's the position for that dog for CPR. There are some weird
Oh.
shaped trees, but yeah, if they
But
if
if
the
you
dog-
don't need sandbags,
yes, exactly. So if they balance, go for it.
well, that's a good rule.
Yeah. What about a Labrador, like a big round-chested dog?
So 1/3 to half of the thoracic width in lateral.
Lateral, yeah. And where's your hand going to be? Is it over the heart or over the widest point?
I think you do the widest point
Widest one, I think.
Good. Yeah.
and try and put something under the lower side of the chest if it's moving.
Dipping. Yeah. Good. So barrel chested, like round chested big dogs, we want to have our hand over the widest point of the chest. What about a German Shepherd or Greyhound?
I think you can aim for the actual heart, but you have to make sure that you have the underside of the skinny chest like packed up.
Yes. Good. So there's no point just rocking the chest down and up in those skinny chested dogs. Doesn't do much. So definitely packing underneath is a good idea. And you want to actually be over the heart. What about cats?
It's like just finger one hand technique. So you just sort of place your like essentially just do that.
Show me your hands. I can only see like the top of your head. There you go.
Hamburger.
Yeah. I can't do that.
I get tired.
Yeah,
Get a
my
hand
clients
cramp, and every time.
every time. Yeah. Oh man. It's like I've got this nerve thing in my arm and it's just like that's like my nightmare movement. So I'm not doing CPR on cats like that, but there was actually a change in the recommendations to say that you can do it similar to you do like a keel-chested dog, like a Greyhound or German Shepherd, but just with one hand, and you kind of float your fingers on the table and use the heel of your hand to do the compressions. So that's another way. So if you're like me and you're on your own, you can't just say, oh well. So they're the updated recommendations. They say actually as level of evidence for there being a difference in outcome of that one and that one for cats is very low. Like it's just people's opinion. So whilst they've added that to the recommendations is that you can do it that way if you're fatiguing, there's that we don't know whether there's a difference in outcomes or not. Okay. What about the rate that we're doing compressions at?
And
I
100,
want to unmute you,
but
Julian.
the song is Staying Alive. You do it to the beat of Staying Alive.
Yeah. There's actually CPR playlists, like where you can just put it on Spotify and it just keeps a tempo of 100 to 120 the whole time. And as long as you're on the beat, if you're at the right pace. So yes, 100 to 120. What about, and Pooja alluded to like the depth of compressions. What do we think about that?
Hard to do, but if you want success, then it's really important to pay attention to that. That's whether like you look at the ECTO2, because you can actually, like at least in the past, that's what I've done. Like you look at the ECTO2, I can tell how effective my compressions are looking at that. Because if you're not giving in effective compressions, you're not going to bring back the animal.
Yes, I completely agree. So in theory, you should compress in lateral 1/3 to half of the width of the chest, and in dorsal about 1/4. Who can judge that from above when you're
Mm.
actually doing compressions? It's impossible. So if you do have people to ask, it's a good idea to ask. If you ask somebody and they say, yep, you're doing enough depth and you're not getting your like ETCO2 targets or feeling femoral pulses, it's probably a positioning thing rather than a depth thing. So the Recover Initiative have now trained 95,000 people worldwide in CPR using their kind of dummies and things. And overwhelmingly, they say people compress too hard.
Oh,
You're compressing more depth than you need to in that setting. And that's not with adrenaline, like that's in a workshop setting where you're not like, probably a little bit stronger than you would be otherwise because it's a like tense setting. So overwhelmingly people do compress actually too hard, which is kind of nice to know. So get someone to check your depth. And if you're not getting the outcomes, move your hand to a different spot just slightly and see if you can get better outcomes that way rather than going harder.
I remember them also saying that people don't allow rebound. So you have to take your hands fully off every time.
That's a really good point. So if you think about the rib cage, it's so rigid. We're not actually massaging the heart. What we're doing is altering the pressure within the thorax. So we compress the heart and then it's actually the release of that causes that negative pressure, sucks air into the lungs, but also sucks blood into the heart from the venous system. And that's what keeps it going around. So if you're not relaxing, you're actually not allowing the heart to fill and you're not allowing air to get into the lungs. So it's a really good point. They did say that in their observing in the workshops, they originally said the biggest problem is people not decompressing enough. And now that they've done so many workshops, they're like, actually, that's not a problem. Like people are pretty good at that because everyone needs a little break actually. But yeah, compressing a little bit too hard is really common. Where are we up to? Oh, so they've sort of specified you should do like 50-50, like compression, decompression, compression, decompression, compression, decompression. I think that's like kind of a given, like you're kind of just bouncing up and down in a rhythmic way, right? But in theory, if you're seeing someone go and doing a really fast compression and allowing more decompression time, that's not as effective as a 50-50 kind of cycle. What about ventilation? Let's start if you're on your own and you have done a quick sweep of the airway, how often are you going to do breaths as you're doing your CPR?
Probably one breath every 6 to 10 minutes, like try and do.
Every what?
Seconds, not minutes, sorry. By then you're there. Seconds.
Ideally, but actually the recommendation is only to do it in the pauses in compressions. So when you're following that CPR kind of guidelines, how long do you do compressions for before you pause? How long do you want to keep it continuous for?
Like
2 minutes.
Yeah, everybody knew that one. Well done. So it's actually every 2 minutes you're going to give some breaths, but you're just going to give a couple because you want to get straight back in. You don't want to pause for more than 10 seconds. But if you're on your own, deprioritize breathing, do it in the breaks, but keep compressions going for the 2 minutes. Prioritize that.
Theoretically, if you're on your own, would you try and intubate or would you be breathing through the nose of the pet without regard to work health and safety?
It's a really good question, actually. So they've now done studies, and this is the next recommendation. So mouth to nose was in their original recommendations. They got some feedback from people who work in areas where leptospirosis is endemic. The zoonotic risk of that recommendation was much higher than they'd perceived in the areas that they worked in, the authors worked in. So they've revised the recommendation for mouth to nose to say only if you're in an area where that's safe.
Right.
Sydney's pretty safe, I have to say. Yeah, unless they died of like
I think the
AKI.
owners are much more unsafe. Best to try.
Yeah, I think so as well. Yeah, they've been living with the dogs. They're already exposed to whatever the dog has. What they did find as a kind of substitute of that is a tight-fitting mask, ventilating with a tight-fitting mask in an ambu bag is just as effective, if not more effective, than mouth to nose. So if you can't intubate, whack a mask on and do kind of IPPV with an ambu bag through the mask. Particularly if you feel like there might be any risk of, or it's a bit gross, whichever. If you have two of you, how often are you going to breathe?
I think it was every 10 seconds, 6
Good.
per minute.
Oh, every 6 seconds, 10 per minute.
Oh, was
By
it?
the way.
Yeah.
Check. Yeah, 10 per minute. Yeah, every 6 seconds. Yeah. So they recommend continuing that. If they're not intubated, you're actually going to do less than that. So you're going to do 30 chest compressions, 2 breaths. 30 chest compressions, 2 breaths. But intubated was 10 per minute.
Hey, Anna,
yeah.
Don't you continuously lose forward circulation if you're stopping every 30 compressions?
I think it's
And you're
actually
not
while you're not stopping.
Oh, right. But if
Yeah, so keep going.
If you're by yourself.
If you're by yourself, you're not breathing until 2 minutes.
Right, okay.
Yeah. So that's for if you've got 2 people, but you've got mask ventilation rather than intubated ventilation, they recommend doing it every 2 breaths every 30 seconds. Whereas if you're on your own, you're just doing the full 2 minutes and then breathing at the end of the 2 minutes. But if intubated is the every 6 seconds one. I don't really know why there's different recommendations for intubated or not. But.
Probably easier to maybe ease of administration.
Oh, I was wondering if it's the amount of pressure needed to get air in. Like you might have to use more positive pressure, which might actually compromise your compressions if you're using a masked one.
And you're more likely to fill up the stomach.
Helen, do you have any insight?
No, I was going to say the same thing. It's because if you're ambu-bagging them, but still doing compressions, quite a lot, if you don't stop compressions, quite a lot is going to go into your airway. So then if you cause a gastric dilation, you're going to compromise your venous return.
Oh, so smart. Thanks, Helen.
Great.
That's such good insight. Okay, what about how much pressure? Like if you're working in optimal conditions and you've got like a pressure gauge on your air, what sort of pressures are you going to be using?
Go up to 15, I guess.
Yeah, if that. Keep it low because we're prioritizing not inflating that too much because we don't want to change the pressure too much and decrease the efficacy of our compressions. What about is there any contraindications to using 100% oxygen in these patients?
Isn't it going to potentially affect their respiratory drive?
Potentially, except their CO2 should be so high, and that's a stronger driver for respiration than high oxygen. But in theory, yes. Recommendations say that the benefits outweigh the risks. So there are some risks in some situations where you may not want to, but you usually don't understand that context when you're doing the CPR. Like it's kind of a luxury to go, okay, well, this dog's got chronic bronchitis and may never get off oxygen if we start on 100% or whatever. So they recommend using 100% oxygen if you've got it, but also said that the just room air is actually very effective and that they haven't got evidence to say the outcome is worse. But most of the time it's easiest to ventilate through an anesthetic circuit that we've got available, readily available in clinics. They said going back to the inspiratory pressure, they said never go over 40. That's the cutoff. Oh, and interestingly, for people who live in tick areas and have a lot of ventilator patients, they said if they're on mechanical ventilation, take them off and do manual during CPR, which I found surprising. I probably would have gone, great, you keep doing that machine,
Yeah.
I'm going to do this. Yeah, anyway, interesting.
Do you know what the reasoning was there?
No.
Maybe the end expiratory pressure is set to be higher than 0.
Maybe. Just turn it down.
Yeah.
Yeah, I found it interesting. It just seemed less exact, but I guess you get, I don't know. So CPR cycles. We already know it's 2 minutes, and there's very strong evidence for that now. And then you do a little hands off. What are you watching for in your hands off?
Pulse. If like trying to feel the pulse to know what to do next.
Yeah. So return of spontaneous circulation. So ideally you've got your ECG on at that point.
Yeah, I think it's easier to read the ECG when you are not jumping the animal around.
Definitely. So that's the main thing. So assessing the rhythm more accurately. ETCO2 as well. That's what happens with the ETCO2. Because when you're going like this, it's going to be going and it doesn't read that well. So it just allows you feel a pulse, change like positions, because you fatigue really fast. If you've done much CPR, you realize it's very tiring. Yeah, start again basically. So it's very strong evidence that 2 minutes is the cycle with the best outcomes. If you need to change compressing mid-cycle, aim to count down. So we always just go, okay, ready, 5, 4, 3, 2, 1, and then just jump sideways really fast, and somebody else keeps going on the same rhythm. So what happens if you don't have an ETCO2 monitor on your patient and you're doing CPR and you think, I'm like 30 seconds into my 2 minute cycle and I'm pretty sure that this animal is starting to like have a return to spontaneous circulation. Do you stop in your 2 minute cycle, or do you keep going even if you don't have monitoring equipment on?
I would say you should keep going.
Keep going, yeah. So you want to be really sure that they've come back if you're going to pause your 2 minutes. So if you've got your ETCO2 and your ECG on and you can see the dog's going, hey, get off the table, then you're fine to like pause. But if you don't have monitoring on, they recommend like don't assume, because there's lots of markers that you might be missing, and you're safer just to keep going with compressions.
So if you have monitoring your CO2 and you've got, say it's 20 because you're doing adequate compressions, and it suddenly goes to 100, that's what you're looking for, is that all of this CO2 suddenly coming out.
Yes. And if you've got it like sitting at between kind of 15 and 25 or something like that while you're doing compressions, the only reason why it would have jumped dramatically is because there's return of spontaneous circulation.
You will also have other markers, like it's not just the CO2 number, because by then, if you're seeing that 100 jump, you will also feel the pulse, you will also see the rhythm, like ECG rhythm change as well. Like it wouldn't be in isolation, I would think.
No, it shouldn't be in isolation, but sometimes I find the ECG tricky to interpret, particularly while you're doing compressions. Because obviously, I mean, we know we can get a return to like a very normal looking sinus rhythm and have no pulses, and that patient still needs compressions. So it's definitely worth, keep going unless you're very sure.
Yeah.
Does that happen during CPR? You get return of pulseless electrical activity, or is that more of an origin rhythm?
That's pulseless pulseless electrical activity. Yeah. So
Yeah.
any regular beat or any beat whatsoever on your ECG that doesn't generate a pulse, you need to be supporting the cardiac function.
So that can occur during CPR. I was imagining that is the initiating problematic rhythm, but that's just a
No.
thing that can happen at any time.
Yeah, exactly. It can, yeah, absolutely. So some, for example, like an electrolyte abnormality, which is causing, like if you had like wild sodium derangement and your like myocardium just couldn't contract properly, you might get like normal electrical signals, and that's what the ECG is detecting. So the electrical pathway in the heart is completely intact, but it's not actually resulting in myocardial contraction that's effectively resulting in circulation. So you can have a completely normal ECG with certain conditions.
Is that generally when you get pulseless electrical activity that there's like a biochemical reason?
No, I've seen it in dogs that are just dead for other reasons.
Right.
As well. But yeah, it's quite alarming when you sort of like, yeah, that's a normal rhythm.
Right.
Quite confronting to me. Yeah. But yeah, it does happen. Okay, what about drugs? So say you can't get an IV in. What are you gonna do? How are you gonna
In the
administer?
past, I've had once or twice where just IV access was just not possible. So the other options, I mean, you can obviously do IO, but what I did was put it to because we had intubated, put it through the ET tube. Not as effective, but then at the end of the day, if that's all you can do, then
That's all you can do. And that's the recommendation exactly. So they recommend like IV. Just keep trying to get an IV. Go IO, intraosseous, if you can't get an IV. But definitely do intratracheal via the tube. Dilute it with saline. And rather than just going into the end of the tube and hoping it gets there, they recommend using like a sterile urinary catheter and going beyond the end of the tube and getting it into the lower airways, just like fire it in there. Basically, most successful absorption.
Same dose. IV dose. Well, it used to be like double or something, but
No. Yeah, they've changed it.
I thought it was double intratracheally as well.
I think
Was
they've
that-
changed it. So one of the big changes that they've made is the doses of particularly adrenaline. So they've changed. We used to have a low dose adrenaline, and then if that didn't work, you move to a high dose adrenaline, and they've changed the recommendations to just doing the low dose and repeating that every cardiac cycle. No, wait, every second cardiac cycle.
every second cardiac cycle, yeah.
Every second cardiac cycle, sorry. So the main drug that we use during CPR is going to be adrenaline, epinephrine, depending on the source that you're reading. So we're only going to use a low dose, and we're going to do that every second cardiac cycle, compression cycle, I should say. So every 4 minutes. Why are we doing that every 4 minutes? Why don't we do it every cycle?
I think because it increases myocardial oxygen demand.
Good.
Too much vasoconstriction.
Yeah. So it's basically just the half-life. It's just the pharmacokinetics of epinephrine. So where the previous recommendation sort of said epinephrine and atropine every second compression cycle, they've actually changed that because atropine pharmacokinetics are quite different from adrenaline. It's much more longer acting, much more long-lived. So if you give one dose of atropine, you're done. You don't need to give another one. It's going to last for the duration of your CPR. It's not the wrong thing to give atropine. Like it doesn't have any negative effects from the research that they've done. But it will accumulate, and if animals do return to spontaneous circulation and they've got a huge dose of atropine in their system, the outcomes are actually worse. So if they've got like no change in outcome, but if they've got multiple doses, then the outcomes are worse.
In the
Um,
previous one, the way it was worded, because I've had discussions about this until this came
Mhm.
out, actually, the
Yeah,
guidelines
yeah.
last year and the year before with the ECC people. It was open to interpretation a little bit. Like you did the two every like atropine and the adrenaline every second cycle, but the atropine, the way it was worded, it was open to interpretation. So some
Mhm.
like some people would interpret it, do it every second cycle, same as like so you
Yeah.
give adrenaline, then you give atropine, then you give adrenaline. Whereas some people interpret it like just give it as a one-off, or you can repeat it if need be. Whereas now it's very clearly stating that atropine, just give it once. So
Just
it
give
is
it
really
one.
good
Yeah.
because I've had like discussions with criticalists and ECC staff about this because like it's interpretation, right? Like so it was
Yeah.
like, what do you guys do? What do you guys do? And people were doing it
There was
differently.
no consensus. Yeah.
Yeah.
And that's like that was a problem with the previous guidelines, but there is consensus now. So we've got a really
This
nice
is good because now it's like just stated.
Yeah, just do it. And what situation would you not want to give atropine?
Oh, never. I've always given atropine for all my CPRs. Like one dose always, like the first go. So,
What about if they've got ventricular tachycardia?
but then if they have ventricular tachycardia, like unless, I mean, as far as I can remember, all the CPR cases I've done, they actually like dogs that actually have CPA. So they've like, they don't have pulse, like they've had pulses activity. I've never actually even had, I can't recall any case where I've actually seen any activity and needed to use a defibrillator, but that could just be like my experience.
Yeah. So that would be the one situation where I would say, like, if
Not
you've got
to
a
use.
shockable rhythm,
Yeah.
a tachycardia, tachyarrhythmia, and it's pulseless by definition, like these dogs are dead, like they've got not generating enough circulation. But if the cause of death is a ventricular tachycardia, you don't want to be giving something that's going to increase the heart rate.
Yeah.
So that's the one situation. If they've got a shockable rhythm, don't give them atropine. Otherwise, it might help. Give it once. Might as well. Give it early in the CPR as well. Like, give it after the first cycle if you're not getting any response. What about, silly to talk about because not many people have access to a defibrillator, but we rarely see rhythms that are shockable anyway. But what about if you do have a dog that doesn't respond to defibrillation with a shockable rhythm, ventricular tachycardia, something like that? What other medications might you be able to administer IV to help with that?
You could give him lidocaine.
Yeah, exactly. Yeah. So a dose of lidocaine for ventricular tachycardia is going to just bring down the heart rate. So sodium channel blocker, it's going to decrease the influx of sodium into the myocardial cells and therefore how fast that heart can contract. So it's just going to slow the heart rate down a little bit, give it more time to fill and make each beat a little bit more effective. It sometimes flicks them out of the rhythm. It's very short acting. So if they do return to spontaneous circulation, they need really close monitoring and sometimes CRIs to stay in a functional rhythm. So very close monitoring after.
If is it a problem to give lignocaine first while you're running up to Woolies to get the defibrillator?
I would, yeah, if you don't have a defibrillator right there, then I mean, yes, just do it, basically.
And you mentioning VTAC, I was imagining that it was just ventricular fibrillation that was the shockable rhythm. You're talking about VTAC as in it's also a shockable rhythm. Do you mean like the animal it's a really, really clinical, there's no pulse?
Yeah, so VTAC and VF are the two main like tachyarrhythmias, greater than 200 repeated patterns. VTAC uncommonly causes pulseless, they've usually got a pulse. It's usually really, really weak because there's only a tiny little getting into the heart between beats and then there's a tiny little bit coming out. So their perfusion is terrible, but they're really dead. Okay,
so it's just as bad as ventricular fibrillation.
It's not as bad. It's just it will probably turn into ventricular fibrillation. Yeah.
And that's still a shockable rhythm. That's still no
Yeah, so if you're seeing like just VPCs, non-stop VPCs, and the heart rate is over 200, it's shockable.
Right.
Okay.
So
Whereas fibrillation,
asystole is not a shockable rhythm.
not a shockable rhythm, exactly right. So rate has to be greater than 200 and has to be repeat complexes with a rate of over 200 per minute to be a shockable rhythm. Asystole and pulseless electrical activity and any variation thereof, don't shock them, just compress them.
Is there any mention of the precordial thump?
No, not in CPR, but definitely in supraventricular tachyarrhythmias. Supraventricular, not ventricular.
Supraventricular. Wow.
So very, very specific indication for a precordial thump. We'll talk about that in cardiology. That was one of my first day of my internship. The vet that was working, he had a dog with SVT, supraventricular tachycardia, and this vet is like huge, just like really, really tall, and this Labrador is lying on the floor collapsed, and he goes, "Hey!" and karate chops the dog on the chest, and the dog just goes. That was amazing. Like, what? I really want to learn from you. Anyway, okay. So what about once we get them back, what tests can we do to see how back they are and whether they're heading towards not being back again? What should we be monitoring?
I guess you could monitor lactate and see that it's improving.
That's the one. Yeah. Excellent. So what are we looking for with lactate? What does that tell us?
It's probably going to start high, but I guess it's only useful serially if you're seeing it.
Yeah, exactly. So you can't just do a one-off. You've got to do it really regularly. What other complications do we see of like post-arrest? What organs are most impacted by loss of circulation or perfusion?
Kidneys?
Brain.
Yeah, exactly. Yeah. So again, serial monitoring to determine the degree of renal injury that's occurred. There will be some renal injury. It's just how bad is it? Creatinine is the one that we've got the most data on, but SDMA in theory should be a good marker of renal injury as well. What about that's probably all. I mean, the rest of it is like we're going to have pulse oxes, we're going to have ECGs, we're going to have blood pressure monitoring on, right? Yeah, hopefully. I think the gut is probably worth mentioning as well. They're going to have lost their mucosal lining of their gut, and maintaining like critical care settings that I've worked in the post-arrest, they just put a feeding tube straight in, or a central line and deliver and parenteral nutrition because they're not going to be capable of absorbing things from their gut for a while.
Is that after a certain amount of time? Is there any indication of how long you've done CPR for that would trigger that?
No, it's probably even minutes. Yeah, because the gut's the first thing. So presumably there's been some lead up to the dying. So there's been a like decreased perfusion over hours at least, typically, or at least like an acute setting. And then yeah, during the CPR, and yeah, they often need it. All right. Any questions?
An anaesthetist that I know maintains that adrenaline's not the best drug to use. A pure alpha agonist would be better. But of course, they're not common, whereas adrenaline's readily available.
Yes. So vasopressin is a really good post-arrest drug. So maintains blood pressure post-arrest really well, but adrenaline is definitely the arrest drug.
What about lecturers at uni used to say noradrenaline would be, he preferred it,
Oh,
Um,
interesting.
but
Yeah, I didn't see that mentioned at all, actually.
I think he had a lot of different ideas. So,
Helpful.
Who was that?
Lee Ladd.
Ah, right. It's the same one that I'm quoting.
Different ideas. All right, we might wrap up. But thank you all for coming. And if you are interested, the guidelines are just free access. So Recover Initiative website has got amazing resources, and there's more stuff coming out that they're working on, like post-arrest management algorithms and stuff like that, which is very handy. So definitely a resource to look up. Recoverinitiative.org, I think. Just Google it. You'll
Just
find it.
Google Recover, it comes up.
Yeah. Awesome.
Thanks.
Good one. Thanks,
Good.
guys.
Thank you, Anna.
Thanks.
Thank you, everyone.
Thanks, Anna.
Okay.
Bye.
And Anna, when do you want to talk about lions?
Can I just what are you doing now?
I'm expecting a phone call, but I don't know when it's coming. Sometime
Okay.
after 9 o'clock. So
Okay.
now is okay.
Okay. Well, why don't I just
Turn the recording off.
yes, that's what I'm aiming for. Right. Stop recording.